If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, Dr. John Riddick, thanks for taking time of your Saturday to do this. Appreciate it.
Happy to be here.
So this is episode 2 of our heart health kind of focus series with experts in the heart care field. For the listeners, if you haven't heard episode 1 with Dr. Reddy, I'd recommend you start there because we really lay the foundation that then John and I are going to build on. But let's jump into it here. So
Sure.
Thanks for doing this, John. You and I are personal friends, and then you became my cardiologist maybe not recently, a year and a half ago.
September.
You have the exact dates. Yeah.
I do.
And I wanted to do in this episode something that I haven't seen enough of, or really any of, which is use my own experience as a patient. And we'll be able to, because it's me and you're my doctor, we can go into a lot of detail that you wouldn't be able to share otherwise. And
I think we're okay.
I think we're okay from HIPAA.
Spoke to our attorney last night at dinner.
Yeah, good. Yeah, good. And I think that what's interesting is that it'll allow us to dive into some more detail that would be hard to talk in generalities. But I also want to caution the audience that each situation is unique to that patient. So even if they have labs that look on the outside similar, they have a different family history, they have a different overall heart situation, different medical situation, and they should talk to their own cardiologist. This is meant to be educational, not...
Or primary care doctor.
Or primary care doctor.
Where your story starts.
Yes, that's right. And so before we jump into my story, I want to just get your personal background. How did you get into medicine at all? I think you knew you wanted to be a doctor pretty early on, but talk about your journey and when you wanted to be in medicine. I think your dad, you have family members that are in medicine.
That's right. So grew up in New Orleans with our mutual friend, Lamar. And my dad was a first-generation doctor. He went to Vanderbilt Med School, did residency at WashU, fellowship in endocrinology. Always thought he would be in Nashville. And in the 50s, basically couldn't find a job in Nashville, moved to New Orleans, started a medicine program at the Ochsner Clinic where he practiced medicine for over 50 years. He was, at some point, became the medical director of the Ochsner Clinic.
So hold on, back up. He started the medicine practice at Ochsner.
He was kind of, Ochsner Clinic, to go into was started in the 40s by a group of surgeons from Tulane who defected. It was primarily at that point, vascular surgery. They didn't really even have heart surgery back then, but it was primarily a surgically driven clinic, kind of modeled after the Mayo Clinic. Okay. They were starting to ramp up their medical subspecialties. Endocrinology was a pretty nascent field in the late 50s at that point.
And just sorry to interrupt, but just for the listener.
Sorry.
The medicine practice is labs, pharmaceuticals, treatments that do not involve intervening and cutting open the body or going into the body. Is that close to right?
Yeah. Internal medicine is more the thinkers, diagnosticians, ordering labs, physical exam.
Where
surgeons are more,
So Ochsner started off as a surgery practice mostly, and then your dad helped them build out the medicine side of it.
He was their first endocrinologist in 1959. And so insulin had relatively recently become clinically available, and he was a thyroid expert. So that was his medical practice, but he moved into a more administrative role, became the medical director of the clinic. He was the first non-surgeon to do that in the 70s. The clinic was separate from the foundation and the hospital. They merged in the 90s. He became the CEO of that enterprise for 15 years or so. And so I grew up.
You grew up as a son of a doctor at the local Ochsner.
Correct.
You went to Duke with the idea that you wanted to be a doctor.
True.
Did you know you wanted to be in cardiology or in heart care broadly, or what was the thought process?
So as we discussed, I had orthopedic surgery when I was a junior in high school, tore my meniscus. Locke Ochsner, actually, one of the Ochners did my surgery. So, like you, undersized running back, like we were.
But you had speed. You had a lot of speed.
No, not at all, actually. And that was part of the problem.
Yeah.
And so, as we discussed, if you are a guy going into medicine and have any athletic history, you immediately think, I'm going to be an orthopedic surgeon. So I would say I went to Duke thinking, I want to go into medicine. If I had to pick a field, it'd be orthopedic surgery.
Okay.
I'd had surgery. That was my exposure. But you really don't understand what's involved with different specialties till you're in med school doing clinical rotations. But I would say cardiovascular medicine or cardiovascular surgery were on the table for me because in addition to being a doctor exposed that way, my dad had a heart attack when he was 47, 48.
Oh, wow. Okay.
This is in the 70s. He was
And how old were you?
I was 3.
Oh, okay. Yeah.
Their treatment was basically lay in the bed for, a week and take it easy. So here he is. He's 40.
So there was no bypass surgery or intervention
really.
that was that effective? Yeah.
No. So angioplasty was
crazy.
Beginning. First, Andreas Grunzig, first balloon angioplasties, late 70s. That was not clinically available. Bypass surgery was available, but it was still more or less in its infancy. They weren't using, not to get in the weeds, and this is Dr. Reddy's domain, the internal mammary artery. That part of bypass surgery wasn't mainstream quite yet. And
when your dad's second heart attack occurred, you were 10. Is that right?
Correct.
So you remember that.
I remember that.
But that still didn't change your idea of I'm an athlete. I might want to do orthopedics or whatever. So you go to Duke and then you went to med school. What year of med school do you start to get interested in the medicine side of clinical work?
Well, traditionally, the first 2 years, at least, things have evolved somewhat. But back then at Vanderbilt, 1997, the first 2 years are more classroom-based.
Okay.
Anatomy,
you're learning everything.
Pathology, biochemistry. And then, you get some exposure, but it's not until you're traditionally your third year primarily, where you're doing clerkships. So going around doing different rotations in the hospital. Mm-hmm. There's some basic ones you have to do: internal medicine, general surgery, pediatrics, psychiatry, and then you start to kind of hone in, as we were discussing earlier. Typically, I find that people sort of sort themselves out, typically based on personality. People who are like-minded typically pick fields, and if you look to your predecessors and see, well, this person seems a lot like me in their interests and the way they carry themselves and what they do, and they've chosen this field, you're just like, well, maybe I should look at this field. And it's kind of a sort of a shortcut to deciding which is the field if you just look at the personalities, because every field has a certain personality, I would say.
And so what is the interventional? So you're an interventional cardiologist.
So
what is that personality?
So we're kind of like the orthopedic surgeons of internal medicine. Kind of, if there's a narrowed artery and it's narrow, it needs to be opened. Like in orthopedic surgery,
opened.
This bone is broken. It needs to be fixed.
Yeah.
In interventional cardiology, this artery is narrowed. It needs to be opened.
You can take an active role in intervening and correcting what's wrong with the patient, or at least that's the plan. You can't always do that. But.
So I'm simplifying it, obviously, but I decided I wanted a field where I could do some office-based clinical work. I wanted to have some imaging exposure where I could read imaging, and I wanted to have a procedural skill where I could actually do something procedurally. And there are not a ton of fields where you can do all three: ENT, orthopedic surgery. There's some surgical subspecialties, but within internal medicine, there's gastroenterology and cardiology. Cardiology primarily, where you can do a lot of clinical medicine. There's a lot of imaging, echocardiograms, stress tests, now CT, which we'll talk about, and obviously as a cardiology. So I did internal medicine. Pick cardiology. Within cardiology, there are multiple pathways within cardiology, but there's the interventional cardiology side. Traditionally, are heart attacks, like you said.
Yeah.
Someone comes in with a blockage, they're having a heart attack, you open it up. There's electrophysiology, the electricians, we're the plumbers.
Yeah.
Then you have the electricians, electrophysiologists who do ablations and pacemakers. Then you have...
Yeah, so for someone who's not a clinician, our audience is sort of a mix of industry folks and entrepreneurs and people that are interested in healthcare innovation broadly. So for the cardiovascular system, there is the vascular system, all of the veins and arteries that are providing the plumbing, as you said, to move the blood around.
Yes.
Then there's the heart that has a physical movement. It's physically pumping through the chambers.
Pump. Yeah.
And there's valves
and
aspects of that.
Oxygenated blood through the arteries,
Yes.
and it all comes back.
And then there is the electrical signal, I guess, that coordinates how the muscles all work together to pump. Is that close
within
to
the
right?
heart?
Within the heart
there's,
muscle, or around the heart muscle?
Within the heart, there are these intrinsic pacemakers which fire off, and then there's the wiring that takes the electrical signal from the top of the heart, the atria, down through a governor called the AV node, then into the main pumping chambers, the ventricles.
Yeah. And so then the physical heart in your chest,
yes,
Dr. Reddy would open up and do surgery to correct something, maybe replace a valve or do something like that. Or bypass, meaning like create a new piece of the plumbing artificially to route
so like
blood
my dad
differently.
had, like it sounds like you find other called conduits, typically that's the veins in your leg or the mammary arteries, internal mammary arteries, where they basically reroute blood from the aorta around the blockage and plug it into the arteries beyond the blockage.
They like create, I think about it in a river system or something. They create a new path for the blood to flow through that didn't exist previously.
And so that is typically done for, depending on where blockages are and the extent of the blockages, then depending on the surgical risk, because there's obviously a risk to having open heart surgery, that is a great option for someone like my dad who is 55 with 100% blockage in one artery and critical blockages in the other main arteries. Classic candid for open heart bypass surgery.
Yeah. So there's electrophysiology.
So they're surgeons.
There's a surgeon, cardiac surgeon.
Yes.
And they are opening you up and working on something.
Exactly.
And then interventional cardiologists would be going into the overall veins and artery system from inside the veins and putting a stent in or doing something not necessarily inside the heart, but adjacent to the heart or in other parts of the body. So
for a heart attack, we go in typically these days in the radial artery.
In your wrist.
In your wrist, 85% of the time.
I thought it was through the thigh. But
femoral artery is the traditional way that we used to do that, but because of bleeding risk, there's been a shift over the past decade where majority in most centers would go through the radial artery, much more easily compressible, less bleeding risk, where we go to the first branches off the aorta, which feed blood to the heart or the coronary arteries. Those are the ones when they block up with plaque, cause angina if there's not enough blood getting there, or a heart attack if they become 100% blocked. So
it's kind of meta, but that is the heart providing blood to itself.
So the arteries carrying blood to the heart muscle.
To the heart itself.
So when those coronary arteries get blocked off and you can't feed blood, oxygenated red blood cells to the heart muscle dies, that's a heart attack.
Right.
So we go in there through the wrist, snake a wire. This is why we say it's like plumbing. Have a long plastic tube called a catheter. Take pictures with X-ray contrast. There's a X-ray camera on top of the patient, and then we feed wires down there if there's a blockage. And then over those wires, we have balloons and stents. Stents are metal scaffolds crimped on top of the balloon that we inflate the balloon. Stent opens up the artery from the inside. You deflate the balloon, take the balloon and wire out. So that's fixing a blockage from the inside.
The stent itself remains.
Permanently.
You take out the tools that you use to get it there.
Exactly.
And the patient walks home that night?
Depending on the setting.
Or one night, but it's a pretty minimally invasive.
Day, if it's a elective procedure and you're doing it for angina, so symptom relief for chest tightness from the heart not getting enough blood flow, you can go home. There are parameters, obviously, to do it safely, but same-day discharge is a very real thing. If you've come in with a heart attack, then there are other issues at play where you're monitoring heart rhythm, heart pumping.
But distinguished from cardiac surgery, the recovery time is significantly lower. That's fair?
Right.
Yeah.
And so Dr. Reddy and I did, my cardiology at Emory, then interventional cardiology at Emory. And I don't know I was hired at Centennial Heart to start
here in Nashville.
In Nashville, a structural heart program. So structural heart is a subset of interventional cardiology, which when I joined the practice in 2008, did not consist of much. But now structural heart primarily involves what's called TAVR.
Yeah.
I don't know if Dr. Reddy talked about this.
We talked about this.
So Dr. Reddy and I started this program together in 2011.
I think the first in Tennessee, or the first in, maybe not the first.
Not first in Tennessee, but pretty early on.
Yeah. And this is, you're going in through one of the veins.
This one,
but you're working
in
on the heart itself, as opposed to normal interventional cardiology, where you might be servicing the plumbing that feeds the heart oxygenated blood, but it's not actually fixing a structure of the heart like a valve.
Correct. So the traditional procedure of coronary intervention, called PCI, percutaneous coronary intervention, are opening these coronary artery blockages. For TAVR, that's transcatheter aortic valve replacement. So we're replacing the valve with the same technology as a stent. It's actually, that's where the concept came from. It's a metal frame, but instead of the stent just being the scaffold, they're now leaflets sewn inside the scaffold. And the original Edwards valve was bovine pericardial tissue. So this concept is the same as a stent, except the equipment's a little bigger. So we can't go in the wrist. We go in the femoral artery. We snake a wire, except instead of going down the artery, it's actually going into the heart chamber itself. Right. We inflate the valve inside the aortic valve and basically open up this narrowed aortic valve with a stent that now has leaflets inside of this stent that take over.
Yeah. So it replaces the valve. It
replaces the aortic valve.
But you do not have to open. It's not, you're not putting them on a heart-lung monitor. You're not stopping
they're
the heart.
awake. In fact, the first one ever done in Rouen, France in 2004, the patient was awake, and we've kind of had a whole sort of journey with this, but most patients are lightly sedated, maybe less even than a colonoscopy for a majority of these cases.
So I just want to
go home the
recap for a minute.
Yes.
Like in the late 70s, the first stents were invented. Is that right? Your dad didn't have access to that when he first had a heart attack.
So it started with just a balloon angioplasty,
which would just like push the blockage to another area. Whether that is good or bad, let's leave for the moment. But it was a step.
It was great. It was actually a lot of progress, but it was incomplete.
Yeah, and so that is 40 to 50 years ago.
Yeah, I think it was 77. Training at Emory, Andreas Grunzig, the developer of balloon angioplasty, was recruited to Emory in the early 80s. He developed this in Austria.
So did you train under him at him?
No, so the historians will know he passed away in a plane wreck in the mid 80s. Doctors are notoriously terrible pilots, and unfortunately,
he was flying.
He was flying, but he developed balloon angioplasty. Came to Emory, recruited by Spencer King and John Douglas, and Emory was sort of the forerunner back then, along with Cleveland Clinic and others. But Gruenzig wanted, as the story goes, wanted to be part of a university, academic university. So he felt like Emory fit the bill better than Cleveland Clinic or Mayo Clinic. Either way, there was a lot of collaboration in the 80s, but there was a famous course, the EPIC course at Emory, where John Douglas, Spencer King, Andreas Gruenzig trained a lot, particularly in the Southeast, a lot of the initial interventional cardiologists, particularly in Nashville. There's a huge Emory connection. So the balloon angioplasty was the first step.
So that's in 77.
77, but kind of catch it. All these EPIC training courses are sort of early 80s, 82, 83, say 84. I think Gruenzig passes away around that time. Then someone comes up with a stent, the idea of putting a metal scaffold on the balloon. So one of the main issues was called vessel closure. The vessel's open when the balloon's there, but you take the balloon away and the vessel closes down.
Yeah.
Or you've torn the vessel, dissected it, and then it's not structurally intact, and so it's at risk for closing down. So then Paul Machat, they created a stent out in California as one of the original commercialized stents that wasn't until 87, 88, 89 that commercially stents really became available.
And what I think is really interesting is that these things build on each other. Like you can't, at least I think it would be hard to imagine a stent before the balloon intervention is in place. Right. And then you and Sinu both are collaborating. There's a surgeon and a cardiologist now replacing a valve.
That's right.
Which would have been impossible to imagine in 1975. But now it's done, and it's much better for the patient.
So by and large, I'd say there are a lot of things that go into the decision to have. We still do open heart surgery for some valve disease and some aortic valve disease. And
Sinu talked through that decision tree a little bit. Yeah.
Okay.
Yeah.
So there's a collaboration. In fact, a collaboration that has been, there was a period of time where heart surgeons and interventional cardiologists, when stents really, the next iteration on the interventional front were drug-coated stents, drug-eluting stents, which the metal frame held the artery open, but there was a scarring reaction where the arteries would narrow back down. So then the next bright idea is, let's put these anti-neoplastic, so chemotherapeutic agents on the metal so that scarring reaction doesn't occur in the arteries. So the first drug-eluting stent, J&J came out with Cypher in 2003. Boston had Taxus in 2004. There became a little bit of a slightly acrimonious relationship between heart surgery and interventional cardiology.
You're funneling volume away.
Yeah. Not always picking the right procedure for the right patient. There are a lot of sort of perverse incentives sometimes in medicine. Yeah. The beauty of TAVR has been, it is a requirement that a heart surgeon and interventional cardiologist as a team have to evaluate the patient, not only evaluate them, have to be in the procedure, involved in the procedure together. So we now have this kind of mandatory valve conference where we use it for all sorts of reasons, where the surgeons and the cardiologists.
Yeah, what is the best course of treatment for each patient? And you go through, there's a lot of subtle aspects to it, but the surgeon and the interventional cardiologists are discussing the pros and cons.
It's it's much better for patient care to have different advantages, people thinking about different options. Because I have a internal medicine and cardiology, then interventional cardiology background. Dr. Reddy has a general surgery, cardiovascular surgical perspective, and you get to hear both, or the patient usually gets to hear both.
Right.
Now,
yeah,
which is good.
I think your dad was probably correct that you have continued to learn. Every patient is somewhat different, and then the procedures themselves have gotten more and more advanced, and you're learning new ways to do it.
So the procedure I do the most of, TAVR, I did 3 of them in training as part of the initial trial at Emory, where when 3 obviously does not make
you're
you
not
proficient.
an expert, yeah.
And particularly these are, the first 3 in the Southeast.
Yeah.
Maybe 3 of the first 20 in the United States. To say that I was minimally involved as the fellow in these procedures, so I had no concept really of what it was like to do a TAVR. But to industry's credit, they have laid out pretty, this is now over a decade ago, pretty well delineated pathways for educating medical systems, hospitals, how to do this safely. and it's been rolled out pretty safely, I'd say.
So how many taverns do you do per year, roughly?
250.
Yeah, that's incredible. So almost one a day, for like work days.
We have the benefit here in Nashville where we have 3 centers doing them. So it's a consolidated effort in Nashville, and there's definitely some benefit to having that level of volume.
Yeah.
Whereas other cities, Tennessee's a CON state, there are not many open heart surgical centers, and that's a requirement to do TAVR. You can only do them in hospitals to do open heart surgery. Obviously, heart surgeons are part of the procedure. There are other non-CON states, not to get political, where, in some cities, say Dallas, Texas, where they have, maybe 15
places that would offer that.
Dallas is a bigger city, but, per capita, it's, it's a little more diluted. And so there's a happy medium.
There's a lot of studies. I think I can maybe try to find them, but I think it's pretty well established that if a surgeon does a higher volume of procedures, the quality is better.
Well, it's laid out in TAVR. There are plenty of articles. There's a threshold. The number is probably somewhere between 120 to 150 a year. Beyond that, it seems like it plateaus, but there's a minimum, there's an incremental benefit to doing more up to a certain number. Yeah. And so if you can
like
get
anything,
to that
I think
number,
if you do something fairly often, you get better at it. Yeah.
It makes sense, which is a good reason to go. If you're out there thinking about surgery, I think one of the best predictors is the number of that procedure done in that particular facility by that particular operator,
Okay, and then the last category of heart clinician is the cardiologist without the interventional cardiologist on the front end. So talk through how that is different.
Well, so there's
maybe
a few
more than
new, So there are now imaging, specialized general cardiology. So I'm at Centennial Heart. We're kind of a bigger, a downtown at Centennial, so a bigger group.
Yeah, you have every flavor.
23 of us now. And so we have 5 electrophysiologists, 7 interventional cardiologists. Then we have 3 imaging specialized general cardiologists who have done extra training in reading cardiac MRI, cardiac CT, on top of the other more basic tenets imaging of cardiology, which are echocardiograms, stress testing. But basically, the distinction is they do CT reading, MRI reading, and now what's called invasive transesophageal echo, which helps guide us during our structural procedures. So we have the imaging-based general cardiologist. Then we also have heart failure transplant general cardiologists who focus on people whose heart pump, the actual pump is weak, who have congestive heart failure, and the sort of end stage of that would be people who need LVADs or heart transplant. Yeah. So that's its own niche. We have 4 heart failure transplant general cardiologists. We do LVADs at Centennial. We partner with Vanderbilt for our transplants, but we have a transplant surgeon who is part of the team at Centennial. So, and then there are just pure general cardiologists who do sort of, one of them runs our lipid clinic, the cholesterol clinic. One runs our hypertrophic cardiomyopathy clinic.
Right. So they would be focused on the medicine side, which means lab testing, pharmaceuticals, maybe lifestyle changes.
Exactly.
Yeah. Okay.
And at Centennial, at least, it feels like everyone has trained at these great places and has all this advanced training. So there are very few, in fact, the only true general cardiologists we have are retired interventional cardiologists who have gotten to that stage of their career. So in some ways we have no general cardiologist, which means
everyone is kind of somewhat that.
Everyone is a general cardiologist,
which is what I need.
Degree, which is
what I need. So that works for me.
I came in, although I'm a structural interventional cardiologist 3 days of the week, but 2 days of the week, I'm a general cardiologist.
Yeah.
1 day of the week, every other week, I'm in Camden, Tennessee, where it's very basic,
all over
almost
the place.
Primary care to high blood pressure to high cholesterol. And so I have, which is what I wanted, a kind of spectrum of practice.
Yeah. Yeah. So thanks for going through that. It's a lot about your biography, but like, there's enough complexity. And the reason I wanted to do this series is it takes some time. I mean, I talked to Sinu for an hour. We'll talk for an hour, but the concepts are understandable. I think it's the plumbing analogy makes sense to me. The details of it, I don't know if I need to know, but like how you put a stent in with a balloon and then you leave the scaffolding behind, right. I can understand the basics of that. And so what I wanted to shift to now is heart disease is the number one killer in America, maybe globally. I think there's something like 2,000 to 3,000 people a day die of some kind of heart disease, heart attacks and heart disease. And yet on the hopeful side, as we just talked through, there's been a lot of innovation building on work that was done in the 70s and 80s, but it's continued and getting better and better. We have a lot of diagnostic tools, and we have a lot of medicines, a lot of pharmaceutical tools, even before you start to get to interventions, whether it is through the vein or cutting open and operating. And so, well, it is a really deadly disease. I think it also is true that I have some hope that we can make progress and continue to fight against it and make people live longer with heart disease.
For sure. I think there's been a real increase in the pharmacologic side of treatment recently with newer cholesterol medicines coming out. We've made a lot of advances on the procedural side over the past 25 years. And not that we don't continue to advance there, we do. I think a lot of the coming benefits and technology will be on the imaging side, the non-invasive side, CT scans, which we'll talk about, but also with early detection comes the ability to get ahead of it with medicines. Not to mention we haven't even discussed lifestyle. Obviously, right, there are some basic tenets.
Yeah, so let's jump into my case, and then I want to try to use it as an illustration, because the audience doesn't care about me personally, except for the fact that it hopefully can unearth some aspects of how other people should think about heart disease. So where I want to focus first is that I believe cardiovascular disease is an accumulation of problems over many years. Would you say that's accurate?
Yes, by and large, it's a progressive problem of multiple risk factors coalescing to the buildup of, when we're talking about coronary artery disease in particular, of buildup of plaque in these arteries that starts narrowing the blood flow. And that's a combination of lifestyle, genetics, blood pressure, blood sugar, cholesterol, whether or not you're a smoker, how much exercise do you get, how's your diet, all these risk factors. Now, there does become a tipping point sometimes where these plaques build up to a certain threshold. Sometimes you're not so lucky, like my dad at the bank, where you probably have a 50, 60% plaque not causing any problems. It, quote unquote, ruptures or unroofs or erodes, and the blood doesn't like that plaque being exposed to the bloodstream, and the blood decides, I'm going to wall that off, put a clot on it to get all that fat, cholesterol, plaque out of the that shouldn't be in the bloodstream. Right. That's bad. Here's a thrombus. Right. Now you have 100% blockage.
Right.
Now
that is
a heart attack.
In general.
So there's a acute event
that you would want to try to patch that up. But if you patch it too much, then you block the whole stream of blood.
So that's your body's. The analogy is, as cavemen bleeding, the body's like, the blood vessels are exposed to things, and you don't want to bleed to death, so the body walls off this bleeding vessel so you don't. But we are no longer cavemen. We live in a society where we're not bleeding to death by and large. We're building up plaque. And so this cholesterol thankfully gets walled away typically in the walls, kind of covered over. But occasionally, if the plaque is exposed to the bloodstream, the body will put a clot in an attempt to, keep that out of the bloodstream. And now have 100% blockage in the artery. You're having a heart attack. This is really what you're trying to avoid, because now part of the heart can die.
It builds
not
up
to mention
over many years, but it can present acutely.
But it doesn't have exactly, back to your point, and with the imaging that we are doing these days, we should be able to get ahead of this. And there are a lot of risk factors that traditionally that we follow, but I think your case highlights the fact that sometimes these traditional risk factors, they're incomplete. There's stuff we don't understand. There's certain things we don't know how to measure, what to measure.
Yeah, and so maybe the patient doesn't always tell their primary care doc. Well, I mean, let me just start on my situation.
Sure.
So I was, a husband, a dad, working a lot. In my 20s and 30s, I got an annual checkup most years, but I wasn't very focused on it. And when I was showing up at that primary care visit, it was an overall assessment of my health in 10 minutes, 15 minutes. I mean, and there's nothing wrong with those two. I was at Heritage Group first, and then I moved over to the Frist Clinic. And I think they both were great doctors. But I didn't bring up to them that both my grandfathers died of heart attacks. On one side, pretty young, at I think 64, 65.
Was he a smoker?
I don't even know. I don't think he was at the end, but it's hard to know if he smoked early on. I could ask my dad that. And then I never brought that up. And so in your 20s and 30s, there isn't a lot of screening for heart disease. And I guess my first question is, what do you have in my records back in the history? And should I have brought that up and been more active in cholesterol screening or other screening early on? Because heart disease, it is building up every year. It's building up. And if there is a family history, would it make sense to be more focused on cholesterol or being attentive to it in your earlier years, or is that not helpful?
I think 100% you should be attentive to your cholesterol. I mean,
always, no matter what. Yeah.
I mean, they check it in the pediatrician's office now.
Yeah. Okay.
So 100%, particularly if there's a family history, your blood pressure, your blood sugar, your cholesterol, your smoking status, your BMI, your diet. I mean, that should always be addressed starting at obviously.
Yeah. So
day one, I mean, from the time you're probably 12 years old, in fact, I mean, in a pediatrician's office, these things should be addressed. And so your cholesterol should be followed closely. Now, if family history of early onset heart disease is a big risk factor, it's usually first generation relatives. So when you talk about second generation grandparents and the lifestyle that people lived probably in the 50s, 40s, 50s, 60s, we're talking, my dad, it's hard to know because diets were terrible. Smoking was ubiquitous. It's hard to know genetically, is that as much of a predictor when you're talking about, I mean, if you say, I have my mom at age 41, not a smoker, has a heart attack, that's a huge red flag.
Yeah.
Grandparents in their 60s and the 50s who had may or may not have smoked, it doesn't move the needle a lot for me.
Yeah. Yeah.
That doesn't mean we don't focus on your cholesterol and all the traditional risk factors.
Okay, so let's pick a time when I was held. Yeah, what do you have as far as my stats?
Well, starting with your Frist Clinic days.
Okay.
June of 2018. You want me? I'll just read out.
Yeah, whatever you think is important to talk through.
From a cardiovascular perspective, your total cholesterol was 215. pretty good. The upper range of normal is 200. Triglycerides, 86. That's normal. HDL, good cholesterol, 74. That's excellent. LDL, bad cholesterol, 124. If you look at the lab values, less than 130 is the goal. So there's a score. Have I showed you this? Well, there's an app.
No. Okay.
Your ASCVD score. And so that's atherosclerotic cardiovascular disease.
And it takes all of those numbers you just read off and somehow weights them in an appropriate way?
It gives you... I should have showed you this earlier. So based on your age, sex, race, blood pressure, and your blood pressure, you were 47. Your blood pressure was 110/72.
Okay, so my age was 47.
Yeah.
Blood pressure 110/72.
Perfect blood pressure. Actually, I would say good cholesterol. Maybe not great, but good cholesterol. Your BMI was 26, which is
little
just
bit
a touch high, but not bad. So these are the inputs here, though.
Yeah. Okay,
And so there they are.
I'll put this.
And history of diabetes, no.
Is this app
Smoker,
available to the public?
no. Yeah.
So I'll put that in the show notes so people can check it out.
ASCVD score. So this is part of the guidelines.
And so the Frisk Clinic uses something similar to this.
But yeah, these inputs obviously are...
Those are the important
Your
inputs.
cholesterol, your blood pressure, smoking status. There you are. And so
Okay,
we get a score that's your 10-year...
So Dr. Barfield, who we're both friends with,
Yes.
Was my doc then. And I think he's great. I like him. He has left practicing full time.
He has.
But other than that, he's wonderful. When I was 47 years old, I had those set of labs. And is it right to say that every primary care doc would have looked at it and said that's reasonably healthy? Yeah.
Your ASCVD score, I want to say this correctly, but it was 1.4%. So that's the percent risk of having a cardiovascular event over the next 10 years.
Okay. So I was 47. I'm 53 right now. So that was 6 years ago.
And so anything less than 5% is considered low.
Okay. Now, that with all those scores, the Frisk Clinic sent me home with a clean bill of health.
Correct.
Yeah. And so now let's move forward to the next one, because the scores don't stay really positive forever.
So,
I know. I don't know how it evolves.
It's a
the
dynamic.
question is, like, how does it evolve, and what should the listener be looking for that is the first thing that happens? Is there a first thing that shows up?
So at that point, I mean, I think you get the clean bill of health. The question would be, do you do any additional tests to ferret out your risk?
Yeah.
So those things would be a calcium score, or there's some blood tests, lipoprotein little a, apoprotein B. Those are cholesterol measurements. CRP, which is an inflammatory marker.
So,
but
we could have ordered that.
You could have, but typically by the guidelines, if you're in a low risk category with your ASCVD score, then you would not.
Yeah. Now,
that.
If the listener is wanting to kind of lean into this and really gather more information, is there any downside to getting the calcium score or lipoprotein little a or apoprotein B? Is that a blood test? What's the calcium? Is not a blood test. I don't think.
The calcium score is a CAT scan.
Yeah. Right.
Lay on the table, no IV. You're kind of in and out. It's typically $69, $70, $50. You can often just go on your own. The only downside is there's a minimal amount of radiation. So for a 47-year-old guy,
the two proteins, little A and B, those are blood tests, right?
Apoprotein B, yes, they're blood tests. So they're cholesterol.
Yeah, they're markers for
markers.
Cholesterol.
There's less
the
data traditionally.
The B seems like the bad actor.
It's bad. Yeah, it's a precursor. It is in many ways the LDL captures it, but not. The LDL is a calculated number. The bad cholesterol, LDL cholesterol, is calculated. based on formula. And so it's not directly measured typically. And so there are times where the apolipoprotein B is a better test, but it's not universally adopted yet. As, it's kind of right now, again, recommended for people in sort of the borderline range.
Which I wasn't really, but there's not a lot of downside. Maybe it's $70, $50 to $70, a little radiation to do a CAT scan.
So the CAT scan, for the calcium score there, I'm pretty aggressive. I think calcium scores are
pretty easy to do.
They're easy to do. We're looking cholesterol. Don't get me wrong; it is important. It's probably the main driver of coronary artery disease, along with smoking and diabetes. But a lot of these other, CRP, which is also a consideration. That's a blood test.
Yeah,
that's an inflammatory marker. Having inflammation is bad.
Yeah,
but it's very nonspecific. You can have inflammation. And what does that mean? I mean, certainly there's a lot of data for it. I'm not discounting it. And there's a whole school of thought using CRP more aggressively. I like the idea, particularly as an interventional cardiologist, a calcium score is actually looking at your anatomy. I mean, it's a simple approach, but hey, here are your arteries. Here is calcium. That should not be there. The calcium score should be 0. Should have 0 calcium.
When you're 47 with that very low risk factors, one would expect the calcium score to be quite low, 0.
Should be 0.
And the calcium score is a lagging indicator, I think.
It's a lagging indicator because the plaque gets developed as fatty plaque that then gets converted.
It's like capped or covered over with calcium somehow.
Converted to calcium.
Okay.
But yes.
Yeah. And
It's a stabilizing thing. In fact, turning it into calcium, atherosclerosis is hardening of the arteries. It's a stabilizing mechanism to keep this plaque, like we talked about, it eroding into the bloodstream and being exposed to the bloodstream. Calcifying it typically walls it off even further, stabilizes it, makes it less likely in the early stages when it's non-obstructive, not narrowing the actual path of the blood flow. It's a good thing, but it is definitely a marker that plaque is being developed, which is not normal.
And so with hindsight, I might have done other tests at that point, but I didn't. So let's move forward to the next data point.
So the next data point was March of 2020. So
2 years later?
2 years later, you're 49.
Like I said, I didn't always hit the annual one that well.
I got to say, this is pretty good, though. It's less, it's 18, it's almost 2 years. Either way, your total cholesterol is pretty similar. 222, triglycerides 49, HDL 77. Excellent. So your good cholesterol is really good. LDL, bad cholesterol, 135. A little worse.
130 is the
130
is the
threshold for
now.
These days we use the ASCVD score, but yes. Blood pressure 112/70, BMI 27. Put on a few pounds.
Weight,
ASCVD score 1.8%. Very low.
Yeah.
Low. In fact, when you input all these metrics, it'll give you an optimal risk based on intervention. So if you gave a statin or you gave a blood pressure medicine or you quit smoking or you took an aspirin, what can you improve your ASCVD score to?
Yeah.
In both those instances on this calculator, your ASCVD score is actually lower than your optimal score. I'm not sure how that happens. I'm not the expert on the calculator. But either way,
but it suggests that a statin is not required.
Correct. In fact, you're not even, but again, I'm not sure. This is where I think, obviously, there are things that we don't know. We're not measuring. We don't know what we don't know. We're trying to figure out.
Yeah, I didn't get a calcium test. I did. Yeah.
Would a CRP been helpful? Would a calcium score have been helpful? I think, we can keep going, but
with hindsight, maybe. But
I'm quick to do calcium scores.
Yeah.
Again, it's an easy test. And in a 49-year-old woman who doesn't have any risk factor, you might argue the radiation risk may, because of breast cancer, it may be a consideration.
Yeah.
For a 49-year-old guy, I think the risk is high
I get
enough.
radiation flying in planes. the radiation is not something that I personally am scared of. I mean, in moderation, once in a while.
And I think it's more on a population level. You know, if you start looking at populations, if we start calcium score screening every 45-year-old woman, are we going to save more lives than we harm by inducing a breast cancer here or there? And that's where it's an individual discussion with the patient and their physician. And so, but I'm definitely more aggressive, even with someone who's, I mean, these are pretty good numbers. Blood pressure 112 over 70.
But the LDL...
I still would have probably done a calcium score.
Because the LDL went up in a way that was... it went from like 110 to 134.
So here's the problem. Your LDL 135, we have a mutual friend who had a heart attack. And that we're not promoting anecdotal medicine, but we are always influenced by cases. And certainly when we're at an age where
we have a lot of friends,
50-year-old guys, and 50-year-old men have heart attacks with LDLs of 135.
Yeah.
Even more frightening, there's a physician I know who had a heart attack with a 0 calcium score and an LDL of 135, which kind of gets us to where we're going. But I mean, there are things that we are still not measuring.
You could ask if you're listening, you could ask your physician, hey, what about a calcium score? Just to get information. And if you do that once every 5 years or 10 years, the amount of radiation is pretty small.
Usually we would say the warranty is good. If it's a 0 score, probably good for 10 years. Yeah. You could be extra aggressive and think about repeating it sooner. But I think again, depending on your risk profile and your age and your family history, the calcium score, I'm a big proponent.
Yeah, right. Okay, so
but by guidelines, you were not a candidate. Yeah. You know?
Okay, so that was 4 years ago.
That was, March of 2020.
Okay.
ASCVD score 1.8. Again, less than 5 is low. 5 to 7.4, borderline. The borderline's kind of when you start to really think about it. 5%.
And that was
risk.
at 1.8.
You're 1.8 risk of an event.
Yeah. But something changes because...
So then, something changes. Yeah. COVID
happened. Yeah. I don't know how that affected my heart score, but it did.
So April of 2023, I was not involved yet, but I don't know if this was a discussion that you brought up or maybe Dr. Barfield decided we're going to check some of these things. So you got a lipoprotein little a, and it was 11, which is normal.
Yeah. Dr. Barfield recommended that.
Got an 8.
I think he had just started adding, like he's drawing blood anyway.
Right.
And he just started screening for these additional markers. That's my recollection of it. It wasn't looking for anything particular.
Vic Gatto going in, demanding it.
No.
Apolipoprotein B, 119.
Yeah, so that was concerning.
Less than 90 is normal. You're elevated there.
Yeah. That was the yellow flag that made him...
Greater than 130 is when we really worry. So you're still not like in a crazy high range on your apolipoprotein B, but that actually tracks though your LDL on this visit 3 years later has gone from 135 to 156. So 156, that starts to really get your attention for a LDL bad cholesterol. Your total cholesterol 256, triglycerides 58, HDL 88. So, I mean, your good cholesterol, really impressive. So now your ASCVD score has gone up, but only to 2.9%. So still in the low range. Your optimal risk, you're now at a range where it says, well, we could bring you down to 2.6% with an intervention, which would be a statin.
Yeah. Now, to give the Frisk Clinic and Dr. Barfield credit, even though it wasn't a bunch of red flags, I recall him calling me and saying this, whatever it is, I can't say a protein B.
Apolipoprotein B.
Right.
Yeah, ApoB.
Is not a good thing to have up above the range.
That's exactly right.
Yeah. That was my translation. I'm sure he said it something differently. And he said, I'd like you to get a calcium score.
That's right. He recommended that you get a calcium score.
And because I am healthcare investor and really interested in this stuff, I had listened to a book called Outlive by Peter Attia, who's he's a doctor, but he's been focused on longevity. And he was suggesting in the book that if you're going to get a calcium score, you might as well get a CT angiogram. Is that close to right? Is that right?
Yeah.
CT angiogram?
Coronary CT angiogram or a CCTA.
Right.
Coronary CTA, coronary.
And I asked Dr. Barfield about that, and his response was, I don't know, but that's not our recommended course of treatment.
That's true.
And that's right. I mean, I think he was accurately portraying. So,
CTAs are primarily for symptomatic people by guidelines.
Because I am a privileged asshole and I have your cell phone, I called you directly, even though I wasn't a patient, and asked
this happens all the time. And it's okay.
Right.
I mean, this is...
but I was seeing, I was at the first clinic 2 floors down from you. Yeah. I would have been referred. I mean, Dr. Barfield would have referred me up to your practice, whether it was you or someone else. At
one point there, I don't know exactly in the sequence, but he refers you to Dr. Honeycutt, my partner.
Yeah.
Which he is our expert he's an imaging expert, general cardiologist, but kind of our chief primary preventive cardiologist.
Yeah, which is
lifestyle,
what I needed. I don't need structural
cardiologist
really yet, hopefully.
Correct, which is no, you don't.
Yeah.
But you and I know each other.
Yeah. So I called you kind of out of band.
Yeah.
And I just asked the question, I think I want this CT angiogram, and yet it's not recommended, which makes me feel like maybe I need to think through it twice. And my recollection is you said there's not a lot of risk to it. You have to take this dye. It's kind of a hassle, but the real barrier is cost. It costs $400 something. Is that well, correct me, where's that wrong?
So just backing up one step, Dr. Barfield did recommend you start Crestor, rosuvastatin, 5 milligrams.
That's right, 5 milligrams.
And change your diet to as much of a plant-based Mediterranean diet.
Right, which I'm already pescatarian.
And so I will say also,
I don't drink.
At that point, your blood pressure was normal again, and your BMI had come down to 25. So a normal BMI, upper normal, but normal BMI, you're exercising a ton, you're almost pescatarian. So there's not a lot of room on your diet. And because one of the key concepts of starting a statin for primary prevention, because, at this point, we're debating calcium score versus coronary CTA. So before you even get to that point, it's plant-based diet. You're pretty much doing it. Do we risk benefit of a statin here? Shared decision-making model. Does it make sense? The risks of myopathy or myalgias or muscle aches are low.
What is so
that's part of the discussion.
5 milligrams statin
of rosuvastatin. That's
a lot of muscle. I haven't experienced muscle aches.
That was a pretty
lightweight.
That's a lightweight. That's about as low initiation. And rosuvastatin is a great statin. It's sort of our newest. It's the side effect profile is pretty good. Although I'm on atorvastatin and have been for a long time, generic Lipitor, and never had a problem. But one of the key concepts is a shared decision-making for primary prevention. Does it make sense to take a statin? The pros and the cons between you and your doctor, the risk and benefit, drug interactions, side effects. By and large, most issues with statins are, in my mind, they're overblown.
There's something with Lipitor and the liver and drinking alcohol.
You have to monitor all statins. You have to monitor your liver function test.
Yeah.
But by and large, these things are reversible. Even if you do have muscle aches, usually
stop taking it.
The times you get in the biggest amount of trouble are when you're taking statins with other medicines that interact, and that can cause some dangerous situations.
So in my situation, I was on no medications.
Backtracking, your ASCVD score has gone up to 2.9% with your LDL 156. Your ApoB is elevated. He recommends this low dose of a statin after some shared decision making with you, and you're already doing great with your diet and exercise. So it probably made sense to give a statin a shot. Then the question is calcium score or coronary CTA, even now, you could argue you don't even need to do any of that.
Right.
Because you have one risk enhancer. It's called the ApoB is up, but it's not way up. Just start treating you with a statin. But I would have done exactly what Dr. Barfield did, which would have been recommended a calcium score or a coronary CTA. And I probably would have started with a calcium score as well.
Yeah.
But for your knowledge and
my requesting for
reading a book,
you get more information from the CTA.
So then to that discussion, yes. So the radiation is significantly higher on a coronary CTA.
Mm-hmm.
This becomes this particularly for women is a consideration.
Mm-hmm.
At 50, you're 52 at this point. A 52-year-old woman, that's not I think a coronary CTA is a legitimate, discussion over lifetime risk.
Yeah. But for a male,
I think, and so again, not to be anecdotal about it, but having seen a friend with a heart attack at LDL of 135 and a friend with a heart attack with a 0 calcium score, and being an interventional cardiologist, I do a lot of heart caths. So that's where I go in and take pictures invasively of the arteries based on my partners ordering CT angiograms, the coronary CTA. I am becoming more and more aggressive with coronary CT angiograms. But again, the risks of radiation, there is contrast, which some people can react to. But to your point, it's the biggest impediment or barrier many times. The guidelines recommend it for chest pain evaluation. We're talking here, you're having 0 symptoms,
right,
for the record, and exerting yourself quite actively.
Yeah, so I'm working out hard and I don't have any symptoms, and yet I'm in someone that I don't worry about radiation once in a while. I'm not like working in a diagnostic center.
So as I'm talking to you, I'm with you. I'm like, I'm not worried about a one-time dose of radiation. Yeah. I'm not worried about the contrast. You're working out hard. So you could say, well, when we do treadmill tests, that is a stress test, right? That rules out blockages more than 70%. So the arteries have to narrow more than 70% to give you an abnormal treadmill test. I'm pretty sure you'll have a normal treadmill test because you're doing it you're working out every day.
Right.
And then you could say, well, could you do an exercise? You could do, and plain treadmill tests are about 60% accurate. They're not the best tests. It's kind of there are times when they're great, but for you, I didn't see the need. Then there's the talk, should we do like an exercise imaging-based study? So there's exercise echocardiograms, exercise nuclear stress testing. But again, these are more tests for people who have symptoms. You're not having any symptoms. So the question is, I think a calcium score is a great start. And then,
but I was asking, could I go up one level more?
And then it didn't take much convincing for me.
Yeah.
I said, you know what? One, you get the calcium score with a coronary CTA.
Right. You get it
so you get that.
Right.
And then 2, you get to see exactly what the arteries look like. You get to see the heart pumping, the valves moving, the heart chamber squeezing. You get all this incidental, which sometimes is a good thing, sometimes a bad thing.
Yeah.
All this ancillary information of your lungs, pulmonary arteries, pericardium, the sac your heart sits in, your pleura, the sac your lungs sit in, you name it. Your chest wall, it catches the upper abdomen, your lower.
Yeah.
And so if there's
a liver, a lot of
information.
And
so
the downsides are you have to tolerate the contrast, which is not fun, but I tolerate it fine.
Usually we give nitroglycerin to vasodilate your arteries and potentially a beta blocker, metoprolol, to slow your heart rate to get good pictures.
See, I got in, and because I have a low blood pressure,
you probably didn't need the beta blocker.
I didn't need those things.
And the nitroglycerin gives you a headache, but sometimes we forego the nitroglycerin.
Yeah.
In fact, one of our friends said, I've done that once. I'm never doing it again. So
I don't think they asked me if I wanted it.
So we have a great imaging team, but not only that, we're lucky.
I went to Premier Radiology.
You went to Premier.
Which was great. It was a good experience. Yeah.
We have the latest, greatest thing at Centennial, the fastest best CT angiogram on the market, CT machine, I should say.
Yeah.
But you went to Premier, which, it's your mistake, but no, I'm just kidding.
Just closer. Just closer to my house.
I'm sure it's more
by a mile.
Yes.
Yeah.
And then, so they had pricing. So this gets to the ultimate question became, well, the barrier inconvenience of getting it. And so I looked at the order sheet they had. I think it was $450 for your CTA because
compared to like
gonna,
50 to 70 for calcium.
Correct.
Yeah, insurance doesn't pay for it.
Insurance does not pay for it.
Now, whether they should or shouldn't is a different question, but they don't right now.
They will not for this indication. Yeah. They will pay for it. It's the best test for people with atypical chest pain, not to go down this rabbit hole. It's the number one, it's the primary recommended test for people with chest pain where you're not clear about exactly, you're kind of low suspicion that it's actually a blockage, but could it be, because back to the benefit, it can look at your esophagus, your lungs, your pulmonary arteries, all these things. So
I went to it as a precautionary matter to gather data.
CTA is usually out of pocket.
Yeah.
And so it's probably cheaper. This is a discussion we had last night. Best way to save money for the healthcare system. You'd be shocked to hear this. There was a move by one of our friends that said all pricing should be the same, outpatient versus inpatient. He happens to, run outpatient infusion centers.
And that also would be good for me.
Yeah. But there is probably, I'm guessing it's probably slightly cheaper at Premier than maybe at Centennial.
Yeah.
Maybe $550 versus $450.
Order of magnitude, but yeah. So we're talking about $500
Don't quote
or
me
less.
on any of these numbers. So.
Well,
they're variable.
I don't work for Centennial, so I can say whatever I want on Health Further. So the order of magnitude is $500 or less.
Correct.
$400 to $500, and the calcium score is under 100, 50 to 100.
Correct.
And so it was not a difficult decision for me to make. I am lucky. I spend $500 on all kinds of stuff that is not as important as this. And so I went ahead and went forward with it. And so what did we find out in it?
One more downside. The reason why we don't do this, aside from the risks we've already talked about, are incidental findings. And so sometimes you find, and this is where it comes to the healthcare at large, the downstream testing that can come from incidentalomas, they're called, incidental findings on CAT scan.
There's a lump on your lung.
And then we're going to have to go down this rabbit warren of, working up a thyroid nodule, renal cyst, you name it. CAT scan picks up a lot. And so
that could be good, but it could also be a false alarm.
Could be bad.
Yeah.
And so that's why it's never probably going to be recommended as a population-based screening tool. But
for
an individual person who's discussing it with their physician. And so just as a anecdote, when we got this new CT machine, CT scanner at Centennial, top of the line, all the bells and whistles, they needed to calibrate it and adjust it. They offered free CT scans to all of our partners. Is to come in as healthy volunteers, just to kind of, and people,
and
by
they
and
show
large,
you the results.
Everyone, you get a formal read and everything free of charge. And by and large, every cardiologist signs up for it. In our group, everyone,
because you're intellectually interested.
Well, you spend all your life dealing with it.
Yeah,
you want
to
know.
See it. Yeah.
Between you and I have a 0 calcium score, but I've been on a max dose of Lipitor because of my family history, and I didn't know additively how it would help me just yet. So I, in full disclosure, did not do it. Mm-hmm. I'd say the vast majority of the folks our age, men, I don't know if our 2 female partners did it, but the men, by and large, did it. One had an overcall on one of their blockages, had to get a heart cath. So this is the negative downstream effect. Had a heart cath. Turns out his narrowing was fine. It's okay.
That was a false alarm.
A false positive.
Yeah.
And that is, so when you talk about the risks, it's false positives, downstream testing, start chasing things.
Yeah.
And then what if he has a heart cath, the invasive procedure? Now we're doing this on our partner and we tear the artery and he has to have a stent. or even worse, go to surgery, or even worse, you could imagine. So then you can see where it is a discussion. But again, I was with you. I'm like, let's
I already did it. So I already made that choice.
Okay, so we made the choice. We pivoted. This is what I wrote. In May of 2023, we pivot to coronary CT angiogram. Mm-hmm. So the results, your calcium score comes back 203.
Yeah, which is way
should
higher.
Be 0.
Yeah, right.
And 0 to 100 is mild. 100, 400 moderate. Greater than 400 is severe. So if I had seen that, if we had just done the calcium score and I'd seen 200, then I probably would have recommended a coronary CTA.
Right.
Anyway, so you
we
made
did
the right
it all
call.
at once, but that was
you made the right decision.
Right.
And so where is this calcium? So the benefit to the coronary CTA, when you do a calcium score, you basically are looking for calcified plaque. It's a pretty, I say low quality, it's low radiation, but what they do, I don't read these, by the way, but they find the calcium plaque, they basically trace it, and based on the density, it's called the Hounsfield units of the CAT scan, and the area, you get a score. So based on area and density. It doesn't tell you, though, how significantly narrowed an artery is. It just tells you where it is.
This is the calcium score.
This is the calcium score.
Right.
The coronary CTA, unless you have some artifacts, blooming artifact it's called, it'll tell you exactly what you need to know. Now, in my mind, this was going to be a 0 calcium score. Your arteries were going to be beautiful, and I would call you and say, I'm glad we did this. You have a 10-year warranty.
Right.
The ApoB's up.
That was your expectation.
We'll do a low dose of statin, and we'll move on. But you have so looking actually at the precise narrowings in there are 3 main arteries. There's on the left side, you have the left main artery, which branches into the left anterior descending, which goes down the front of the heart. Some people refer to that as the widowmaker. We try not to use that term. Circumflex artery on the left, which wraps around the side, and then you have your right coronary artery on the right. And so when my dad had his heart attack, his right artery blocked off in the late 70s, and then he went in, and his LAD, the widowmaker, had a 90% blockage. So you have a 50% blockage in your left anterior descending.
Right. Which that was
primarily
shocking to me.
Calcified plaque, which is good.
It's good that it's calcified.
It's not a mixed plaque. It's not a soft plaque. It's not a thin capped, to the extent that CT can define that.
So it's
50%.
It's relatively good. It's 50% blocked, which sounded very negative to me. Still sounds negative to me today.
What's not normal?
Yeah, it's not good.
Some people say, well,
good.
Isn't that expected? And I mean, just because we expect to see it and we see it a lot in Middle Tennessee doesn't mean it's normal or good or should be ignored.
My calcium score should be 0, and it's 203.
Yes.
And the arteries that provide my heart with oxygenated blood, one of them, nicknamed the Widowmaker for bad reasons, is 50% blocked. And
true.
I was very nervous about that. And your response was, there's no way it's good, but we don't need to put a stent in until it's much more blocked.
So the indication for stents are primarily, the best data is for people having heart attacks. They're at a minimum having chest pain or angina.
But I have no symptoms.
With high-risk features. So without any symptoms, then there's no indication. Now, the first step is...
At some percentage blockage, you have symptoms.
Yes.
I mean, by definition. If it's 100%, you definitely have symptoms. Somewhere between 78 and 100, most people begin to have symptoms. Is that fair?
Yes.
Yeah.
And so if you come in with a heart attack, obviously, and we're checking blood work, we're checking a protein that's released from the heart muscle when it's damaged, called a troponin. When the heart muscle is damaged because of lack of blood flow and the cells die and releases this protein in the bloodstream, this is when, obviously things have taken a different turn, and you're going to have a heart cath. We're going to be ready to put a stent in. If there's severe blockages everywhere, you need to see Dr. Reddy and have bypass surgery. Based on your surgical risk.
So with my results from the CTA, I spent my $450.
Yeah.
In my mind, it changed the course of treatment because we learned a lot of data that we weren't aware of before that reading.
Yes.
My statin
So you went,
increased.
I thought, as it turns out, you went from, based on that, you went on a baby aspirin. So there's a lot of conflicting data about baby aspirin for primary prevention, so preventing a first event. As a rule, if your calcium score is over 100, I think there's a benefit to a baby aspirin in someone who's low bleeding risk, like yourself.
Yeah.
And then your statin, I thought, turns out went to 10 milligrams, which is still a moderate intensity. And 20 and 40 are considered the high intensity doses of rosuvastatin. So you went from, before you ever started, you were prescribed 5, then we got that data, and then we started at 10.
Yeah.
I don't know.
I'm
somewhere
at 40
between
right now.
So yeah, so
I think what happened is I came in 6 months later or something like that.
So you went on 10, and then that was from an LDL of, we'll keep it simple, LDL was 156. So we repeated it in September. And on 10 milligrams of rosuvastatin, your LDL went down from 156, I said, to 100. So that's pretty good. But in your HDL, again, as always, 78 was excellent. Triglycerides, 50. Total cholesterol, 188. So we didn't like that. I didn't think that, I think our target.
It was improved, but not, I think you wanted it 70.
70 or less.
Yeah.
Yes. We wanted it 70 or less. So we bumped you from 10 to 20. So then in February of this year, your LDL was 80 on 20 of rosuvastatin. LDL 80, HDL 68, triglycerides 54, total cholesterol 159, which was improved. But again, we're kind of walking you there.
Right.
Then we bumped you from 20 to 40.
Right.
And now we're waiting.
And I have no negative side effects on the 40, as far as I can tell.
And that's the max dose of a statin. So you're on. I think whatever we get with that is what we're going to get from a statin.
Yeah.
Now, based on your next reading, their consideration would be something called Zetia, which is a non-statin cholesterol medicine. It's a pill. But I'm pretty confident looking at the trajectory, your next reading will be LDL less than 70. Yeah. Which is why we were discussing doing it. And
right. And so the hope is, let me make sure I have this right. I think it is if I get below 70 of the LDL, which is the worst one,
worser one. Is the bad one.
That below 70 suggests that you need some level of it to live your life. Your body needs some cholesterol. Is that fair? You couldn't get it to 0.
So because there was some thought you could be too low and run the risk of, the thought was cholesterol is important for cell wall integrity. There was a theoretical risk for intracranial bleeding if your LDL got too low. I think that's more or less debunked, and that the guidelines would say there's no level that is too low. There's no lower.
So the lower the better.
It's not a J point thing where you get to a certain point and you're actually worse off. So
what does 70 indicate? Does that mean that I'm not building up new plaque in the best education that we know?
So this is the key now. So you have this 50% blockage.
Yeah.
And right now you're scheduled to see me in a few months with a treadmill test.
Yeah.
Because just to confirm that I trust that you're not having any symptoms.
Yeah, I will call you if I have symptoms.
We're going to prove it on a treadmill.
Yeah.
And see to make sure that area
and we'll get another cholesterol score.
And we'll check your cholesterol. And we'll decide, there is no level that's too low. So you can, because of artifactual readings, it's a calculated number. We now have injectables, Repatha and Praluent, which are every 2 weeks self-injected. PCSK9 inhibitors, different mechanism. Typically, for someone like you, I don't think we're going to get to that point with where we are, because it's just between you and I, it's a pain in the butt.
Yeah.
Give yourself an injection every 2 weeks for a number. But you can actually get down to negative cholesterol, negative LDL numbers because of
the way it's calculated.
Yeah. But you can get direct LDL measurements in the single digits, like teens, like
so
unbelievably.
The lower the better.
The lower the better.
My body would not be getting worse. The blockages and the
goal is, we don't want any more buildup of any more plaque.
Right.
Now, this plaque is calcified, so you can say, well, can I make it go away? Well, probably not. A calcified plaque is probably there to stay. There's some evidence for mild regression with fatty plaque, but the bottom line is, for someone like you, it's a stabilization thing. We want to prevent any progression. We want to prevent any events.
Yeah, I want to die of something else, not the Widowmaker being 100% blocked.
And so to your point, usually, in theory, you'd like to think it will progress in a stepwise fashion if it were to progress. Hopefully it won't. And you would have symptoms. But what we really want to prevent is an erosive acute event where you're having a heart attack. And that's where the aspirin comes in. That's what aspirin does. It's an antiplatelet agent, prevents platelet-derived thrombus from forming, and the statin also stabilizes everything. And so that's the goal, is to keep this from progressing at all. And if it stays 50% for the rest of your life, well, then no harm, no foul.
Yeah, I mean, I seem to be functioning okay with 50% blockage now, but it got my attention, definitely. Yeah. And the statin does not have any side effects today for me. And so in a month or so, we'll do the stress test and do another cholesterol.
Check your cholesterol.
Hopefully we'll be
check
down
your
at
LFTs.
60 or 50 or something. And
I imagine it'll probably be in the 60s.
Yeah.
And at that point, I don't think I'd recommend Zetia, which would be the next step, the pill. But then the harder part, so stress testing to rule out greater than 70% blockage. The question becomes, well, when can I repeat the CTA and see exactly what it looks like? At least that's what usually people ask me. And that's where you really have to decide what's the additive value in that. That's another radiation exposure, all the things we discussed. And so I have been, I won't say strong-armed, but mildly strong-armed into repeating a coronary CTA on a 2 to 3 year interval on someone. And it's not the end of the world. I don't know if it's going to change your treatment plan, which for this person, this individual, it would have. They were ambivalent about increasing anything. They wanted to see. For you, I think we're committed to my max treatment plan.
My current philosophy is I want to get the cholesterol down as low as possible. I'm open to...
So maybe we need to talk about Zetia.
I'm open to in Zetia injections.
Or Zetia is just the pill, but then...
Or so we can talk about it. I think I like the trajectory. I don't have it in front of me, but I went from like 150 to 100 to 80 and 70 is the marker
target.
That is...
that's our guideline.
Better if I'm below that. So like I'm trending pretty well, but once I level out, if I'm leveling out at 68, I might want to talk about Zetia. If I'm leveling out at 38, then we should discuss it. I want to be not close to the edge because it's my heart, and it's scary. And if I don't have side effects from the medicine, I feel like I should do what I can do to prevent it.
Yes, I wholeheartedly agree. I'm a huge proponent of statins. I'm an interventional cardiologist again, and I have my biases, but I live several days a week taking care of people having heart attacks, and often the risk factors, they don't necessarily line up all the time, which is indicator that we have more work and research to do. But we especially this day and age, there's a lot more. Not to get political, but medical skepticism, questioning of, the healthcare industry and big pharma. And so we deal a lot of the time with statin skeptics, statin intolerant, as we discussed. Some people think they're intolerant. Often it's not true intolerance, but
my mother-in-law heard about this story, and she said to me, statins are evil. You shouldn't be taking statins. And my response was, well, I've already taken them and I have a 50% blockage. So I'm going to do what my doctor said. But there is that out there. Whether it is real or not real, it doesn't matter. There's some people that think that.
I mean, some, most cardiologists would say sprinkle statins in the water, but
that might be a step too
there
far.
There are theoretical risks of slightly increased risk of diabetes. There's a question of long-term risk of dementia on statins. My response is typically, if you're having your blood sugar monitored, that doesn't matter. I don't think that's ever going to be an issue for you. The most common cause of dementia is vascular dementia, which is from atherosclerotic vascular disease.
Yeah,
I think it's a risk-benefit thing.
Yeah.
So I don't think statins should be in the water. And I think you should always have a healthy skepticism before you ever start a medicine, which is why the whole basic tenet, again, for primary prevention is to discuss the risks and benefits. The harder time are, someone's come in near death with a heart attack, and then you're seeing them back, and you still can't convince them to take a statin. But, sometimes you can't convince people to quit smoking either. And so that's, people are going to make decisions. And
for me,
just provide the evidence.
It's a generic medicine, not very expensive, and it's very tolerable. I take it once a day. It doesn't seem like it. I haven't noticed anything. So the last question I have is that I have two sons who are in their teenager years, right? So they're young. Should they get a calcium test anytime? Should they just monitor their cholesterol? Should they do the apolipoprotein B, which seemed like the trigger for Dr. Barfield? That was easy. That was just already in the blood work. But easy from my point of view. I don't know if it's easy for Centennial.
No, it's easy. It's easy. Again, by guidelines, would not be recommended. I think having blood pressure, cholesterol, blood sugar, not smoking, healthy lifestyle for someone who's, your sons are 17 and 19.
But I do think that when they turn 30 or something, they maybe should check it.
Correct.
There's not a lot of downside to getting a calcium test when you're 30 or
I think the question is it's a risk benefit again with radiation with a calcium score. It's low risk. It's a matter of what are you going to do differently with the information. For instance, had we checked your calcium score in 2018 when all this started?
Yeah, if it had been
your LDL
100,
was 124, your risk score was 1.4%. So I don't think it would have been. I'll be honest.
Well, it should have been 0.
It should have been 0.
So if it was not 0, that would have been another risk factor.
I bet it probably would have been less than 50, though. Probably would have been 20 or 30.
Yeah.
No way to know.
I think it would have been positive, not 0.
I agree.
And I would have started a statin then.
I agree. But that would have been at age, you were 47.
Right.
So that's a different question than 20.
Yeah, right. Yeah,
so
I don't think below 30 it really makes sense. But somewhere 30 to 47, I think it maybe does. If you have, now they have reason amount of family history now because I'm their dad, and then my dad has AFib, which I didn't know at the time. It's happened in these last 5 years. He's gotten it.
So AFib,
not related.
No, not generally.
Yeah.
You can. It's your heart. So to say it's completely unrelated, but for your dad, he's never had a heart attack, right?
No.
Never had structural damage because of coronary artery disease. That means AFib is often a reflection of high blood pressure, sleep apnea, other risk factors for AFib that cause things that make your left atrium enlarge. So it's a little different. They're related spectrum than coronary artery disease, but AFib and coronary artery disease are not directly linked unless you've had a heart attack from coronary artery disease, which then causes your left atrium to dilate. But AFib in your dad, if there's no good explanation, is probably a risk factor for AFib in you. So that's something.
My blood pressure has been good for a long time.
Your blood pressures are perfect. You actually have a negative sleep study in there too.
Yeah,
we didn't talk about that.
My wife,
which is important to always think about.
Was sure. Well, she was positive that I had sleep apnea because I snore, but I went and got a sleep study,
which is a great thing.
Which was not fun to do, but great to have the results because I didn't have sleep apnea.
you probably have more nasal septal issues or
right.
So snoring, but there's definitely, for people we see with high blood pressure, certainly AFib, sleep apnea screening is always on the list of considerations for sure.
Yeah.
But to your point about the kids, it's a great question. At what point do we start checking these risk-enhancing risk factors, the ApoB, the lipoprotein(a)? The lipoprotein(a) is usually like, it's a one-time test. It's either you have it or you don't type of thing. And that is not unreasonable. Given that yours is normal, I doubt that's probably not going to be a risk enhancer for your kids either.
The way I think about it is that I need to communicate with them. To me, like people that are listening, you should talk to your kids, talk to your parents so that you understand your own family situation. And then if they have a LDL score or an apoprotein B or A that is on the edge of, it's starting to get slightly high or it's trending in a way that is not good, then you could then use that and talk to your doctor and discuss, like, does it make sense to run another test? Calcium score is not without risk, but it's not dramatic risk.
I'd agree. I have a low threshold for calcium scoring. And most of the incidental findings that you run in there with lung nodules they're pretty minor. And depending on who you're using it to screen, I found several people with aortic aneurysms and other not so great things.
Yeah, which is good to catch.
That is very good to catch. And the coronary CTAs, again, because of all the stuff we've talked about, I'm not sure if it'll ever be kind of everyone's just going to get one, futuristic. Everyone's just going to get zipped through the CAT scanner to see. Kind of like everyone gets a colonoscopy. I don't know if we'll ever get there. I think the technology, it's certainly improved, and it makes it, for me, pretty easy to be convinced. Like after our discussion, I'm particularly for 50-year-old men.
Yeah. For me, it was worth the risk of additional radiation and the contrast and finding something that would send us on a whole nother track and the cost. And it ended up, which it wouldn't necessarily with everyone, but it ended up unearthing a lot more information that let you, as my cardiologist, better advise me on to increase my statin and now monitor more carefully.
Right. So I think in
my case, it worked out.
In the right patient, it's great. And for people with chest pain, it's fantastic these days.
Yeah.
So, and the technology, we haven't even talked about AI, but the AI components that go into CT reading, we didn't talk about FFR, which is a way to analyze whether or not that 50% blockage is obstructing flow. I think it's not. There's a way to measure whether hemodynamically is it actually the sort of add-on sort of analyses they do on CAT scans now. It's pretty impressive.
So did I have that on mine?
You did not.
Did not. Yeah.
Well, it was done at Premiere, so.
Yeah.
No, it's newer. It's pretty new kind of technology, and we're doing a lot of correlation between CT, FFR, and then going to the cath lab and directly measuring the flows in the arteries with invasive techniques. And so, AI.
Well, hopefully, I'm going to manage my diet and take a statin, keep my LDL low, below 70, hopefully half of that, and not be in these very complex interventional things. But it's good to know they're there if I need them.
Yeah. Well, again, technology keeps moving forward.
Yeah.
Keep learning new techniques. So.
Okay, Dr. Riddick, thank you for doing this. Very helpful.
My pleasure.
A lot of data in this episode, but I think it is helpful. People can listen to it and then make some notes. They can talk to their primary care doc, ask. I think the real key is empowering the patients to have a meaningful discussion with their doctor about what does this mean? How does it affect me? Because each patient's different, but arming the patients, I think, ends up in a better place.
For sure.
So.
And you got to ask sometimes.
Yes. Okay. Thanks for your time. Appreciate you taking a Saturday to do this. Great.
My pleasure. Thanks, Vic.